Welcome to Medical Grand Rounds. I will take this off for the moment. I'm Bob Wachter, Chair of the Department of Medicine. Welcome to our in-person guests who are enjoying a wonderful lunch and seeing each other, and also welcome to the folks that we have watching virtually. We will continue to do these sessions in hybrid format forever, we think. But periodically we'll do a virtual only when the speaker is virtual. And the next one that I know of is our next COVID Grand Rounds, which will be, as always, the first Thursday in the month. That's June 2nd. And we'll have a special guest, Ashish Jha, who is our former resident and is now the White House COVID coordinator. So it'll be in conversation with Ashish on June 2nd. Today is another special occasion. This is our yearly Alice Hamilton Memorial Lecture in honor of the pioneering leader in the field of occupational and environmental medicine. And so each year, the Division of Occupational Medicine, led by Paul Blanc, invites a national world leader in the area of occupational medicine to discuss an issue that's topical, and this year is absolutely no exception. The topic today is respiratory health after military service in Southwest Asia and Afghanistan, insights for clinicians. Our speaker is Dr. Eric Garshick, who's professor of medicine at Harvard Medical School and associate chief of the Pulmonary, Allergy, Sleep, and Critical Care Medicine section. I see you have as many components to it as we do at the VA Boston healthcare system. Eric received his MD from Tufts and a master's of occupational health from the Harvard Chan School of Public Health. He practices clinical pulmonary medicine at the Boston VA and has also done pioneering research in the health effects of inhaled particulate matter. He's been the member of a number of federal task forces, including for the EPA, the Institute of Medicine, the International Agency for Research on Cancer, looking at the effects of exhaust and particulate matter. He's currently co-chair of a VA cooperative study with our own Paul Blanc entitled Pulmonary Health and Deployment to Southwest Asia and Afghanistan, Assessing Associations between Deployment-Related Particulate Matter Exposures and Pulmonary Function in Veterans, and today's lecture will be on that topic. So Eric, welcome.
Thank you.
Be here and
thank you
for hearing it.
No, I'm truly glad to be here, and thank you for those kind words. I practice pulmonary medicine and I do epidemiology, and what I hope today is to show how these naturally go together and how the epidemiology gives an insight in how we care for our patients. So just a few disclosures. I am co-study chair with Paul on our VA cooperative study. I have grants from the NIH studying respiratory health and air pollution. And another one of my interests is neuromuscular disease, and I have some royalties from Up to Date on a couple of panels on spinal cord injury. So just a little bit about the Hamilton Lecture, and she's an amazing woman, the founder of the modern discipline of occupational medicine, and she lived a long life, as you can see by the dates on the slide. She graduated from Michigan Medical School. She became interested in pathology, but not to practice medicine, become a research scientist. And her accomplishments are numerous. And she really was on that cutting edge of making observations and implementing them for the health of the worker. And many laws and regulations were passed based on her observations. Poor working conditions contributing to tuberculosis spread, dangers associated with the manufacture of lead oxide, and explosive manufacturing. In 1919, she was considered the leading expert in industrial medicine and was appointed at Harvard Medical School as the first woman professor. She was also quite the social activist, and in 1963, she was not a young woman, but she wrote a letter to President Kennedy urging him to withdraw US troops from Vietnam. So really a woman who had some amazing interests. And I'm glad to be here today to talk about this emerging problem among our veterans. So the lecture overview is I'm going to give 4 patient histories, 3 of which I took care of, one of whom appeared in New England Journal of Medicine recently, the case report. I'm going to review military and occupational environmental exposures, talk about PM 2.5, particulate matter less than or equal to 2.5 microns in diameter, which includes the size fraction that deposits deep in the lung. I'm going to give an overview of some of the health effects that have been observed in deployers, the epidemiologic studies, and some clinical case series and pathologic studies. and then go into our VA cooperative study, which is designed to address a research gap regarding exposure. What are the exposures these veterans have had? And then end with some clinical approaches to help you when you see patients like this in your clinics. So the first patient is a 38-year-old man who I first saw in April 2011. He entered the Army in 1995, no asthma or smoking history, and he was completely well, had some mild rhinitis while working in a local armory prior to deployment, and he was deployed to Iraq in between 2006 and 2007. And his job was to retrieve burning vehicles after a battle. He would go out and get the papers and the vehicles and make sure they got destroyed, and was exposed to a lot of smoke in the battlefield that way. In Iraq, he was treated at least 4 times for what's called bronchitis and wheezing, and once for pneumonia with antibiotics. He was discharged in 2009, and every 3 to 4 months, he'd seek help what appeared to be a respiratory infection, cough and phlegm and dyspnea, would get antibiotics, which really didn't help very much. And he would note exertional shortness of breath, particularly with cold air. So when I saw him, his exam was normal. And in April 2011, his pulmonary function tests were completely normal with no bronchodilatory response. We did do a cardiopulmonary exercise test that reproduced his feeling. He got one, he felt congested, had a 10% drop in FEV1, which was a significant drop. And then seeing him back in June, his lung function had dropped. 13% in FVC, 15% in FEV1, and he had a vigorous bronchodilator response. Allergy skin tests were positive for multiple environmental allergens, and we diagnosed him with asthma, added inhaled steroids, allergy immunotherapy. He had a prominent rhinitis component too that developed, and a long-acting beta agonist was later added. And his symptoms have improved, and we've managed his asthma longitudinally quite successfully. The second case is a 55-year-old man who I saw in the fall of 2015, and he was in a National Guard and was a helicopter gunner. And he had made many dusty landing areas and desert areas, including during training, where they would land in the Southwest in this country to simulate desert conditions. He had 2 tours in Iraq for 2.5 years, 1 tour in Afghanistan for 6 months, returning the beginning of 2014. In 2015, in the fall, he complained of mild exertional dyspnea after working out, and we gave him a trial of albuterol. There was no past asthma, no allergies, no smoking, and his pulmonary function tests were perfectly normal. In early 2016, the dyspnea got worse, and he was out raking some leaves in his yard, and as you noted, that was a particular trigger. And his lung function, FEV1, had dropped by 12%, and he had developed airflow obstruction with a decreased FEV1 to FVC ratio. The exam was still normal. He had allergy skin tests were multiple positive to environmental allergens. We also diagnosed him with asthma. We started on a long-acting beta agonist and inhaled corticosteroids, and his symptoms went away, and his lung function got better. So 2 cases of asthma seemingly after deployment. Now, patient 3 is a woman I just saw recently. She's 61. Just saw her a few months ago, and she worked as a Navy corpsman, but was deployed to Camp Allergy in Kuwait, which is a big Army base in Kuwait, for 10 months in 2008. And her job there was not in the hospital setting, but she inspected diesel equipment, including trucks. And she described exposure to exhaust during these inspections, sandstorms. There was a burn pit located at the edge of the camp. I'll be talking about burn pits in a moment, where garbage was burned and the smoke would regularly enter her workplace. She was seen twice during deployment due to sinus congestion. She returned complaining of, quote, sensitive eyes, nasal congestion, and sinus congestion causing a cough. And this improved over the years. I was seeing her many years later after this, but she was left with chronic rhinitis and cough, but with no wheezing. She had no prior history of any asthma or rhinitis, no prior history of nasal complaints before deployment. She's a never smoker. Her blood tests for specific allergens were negative, this RAS panel. Her pulmonary function tests were completely normal. and she currently has very mild nasal symptoms, control with a daily antihistamine and nasal steroid spray, and she is fully able to exercise. So another exposure with somebody having rhinitis causing a cough, but really what not appears to be asthma. Now, the fourth patient appeared in the New England Journal of Medicine about a month ago, a 35-year-old man with 4 years of cough and dyspnea, and he was unable to pass the police fitness test and gained 28 pounds due to decreased physical activity. He's a pack-a-day smoker. He had quit 3 years early before being seen. No asthma or seasonal allergies, and he was deployed over 2 years in Iraq. And he used to deliver garbage to an open burn pit. So he essentially worked at the burn pit where the garbage was burned. One of his jobs was burning human waste in large drums of jet fuel where he would smoke that caused cough and phlegm. He had to stir in the human waste to make it get burned, get disposed of. On examination, he was BMI of 33, so obese, no wheezing on exam. The PFTs showed no obstruction, but had a restrictive deficit with a symmetrical reduction in FEV1, FVC, and TLC. I had a negative methylcholine test, meaning that he didn't have bronchial hyperactivity. Had an exercise test that only lasted about 4 minutes, stopped due to severe dyspnea. He had a very low VO2 max, as one might predict, and reduced ventilatory reserve. So appeared to have a somewhat ventilatory limitation that contributed to him stopping work. Now, he had an expiratory CT scan, inspiratory and expiratory CT scan, and this is the expiratory CT scan. On the arrows, you can see areas of gas trapping, and this is a finding that suggests small airway disease in the right clinical setting. All the other causes of this. Because of severe symptoms, he ended up having a lung biopsy, VATS lung biopsy, and he was diagnosed as having constrictive bronchiolitis, a condition affecting the bronchioles characterized by subepithelial fibrosis that widens this distance here between the airway epithelium and the smooth muscle. And you can see the arrows pointing to the fibrotic deposits that constrict the airway. So he was treated somewhat empirically with bronchodilators and azithromycin 3 times a week, which is actually used in treating the bronchiolitis seen in lung transplant recipients. Received pulmonary rehabilitation, and his dyspnea approved over 2 years. So yet another case of somebody with small airway findings on biopsy post-deployment. So I've talked about 3 syndromes post-deployment here. So let's now talk about our deployments in this part of the world. So in Afghanistan, there were 2 formal deployments ending in 2021, as we all know. And in Iraq, there was Operation Iraqi Freedom, OIF, and Operation New Dawn, OND, that ended in 2011, and greater than 2.7 million troops were deployed. So the exposures experienced during deployment represent a combination of occupational and environmental exposures. There was exposure to ground dust from dust storms, convoys and military operations in the desert area, burn pits, disposal of garbage with smoke, engine exhaust from trucks, tanks, and aircraft, and generators, since the power came from banks of generators in the bases. Other open combustion sources like my patient, that's combat-related and burning vehicles. And also, we can't forget about the military occupations. And there was a large amount of troops engaged in vehicle and aircraft maintenance, refueling, construction to support the combat operations. So let's talk about the desert dust and sand that really represents unique exposure for our troops. So these are very large desert regions. The dust storms go between 50 to 100 days a year in Iraq. And the sand carries not only the sand particles, but fungal spores and grass and plant pollens that are hypothesized to act as allergens. And what you see here is Al-Assad Air Base in Iraq in April 2005, and a file photo showing a large dust storm, and Camp Bastion in Afghanistan in 2014, where these large clouds of dust would simply envelop the camps. Now, I have a colleague in Kuwait, who took this picture of a highway in Kuwait just last year after a dust storm and sent me this video just to illustrate. I think it's playing here. So you can hear it, but it's not playing well, perhaps that can be seen over the airwaves here, but I'm sorry it didn't play on this particular slide. But you can see it basically what you could see is sand whipping across the highway that this person is standing on. There we go. So what about burn pit operations? So the burn pit operations, you couldn't call the garbage collector to come and take away the base's garbage. And the solid waste was managed by open air burning. And at these large bases, they ran continually with lots of visible smoke that would come over the camp. These were phased out by 2010 in Iraq, but they were still in operation in Afghanistan in 2011. And you can see some file pictures here of women, soldiers throwing uniforms and other materials into the burn pit, another burn pit worker here, and you would see walking down the highway, this visible smoke representing burning garbage. And not only were there burn pits from the US military, but from other countries and from the native populations. So this is a very dirty, smoky area that our troops were working in. So if you could go into the smoke that was coming out of these burn pits or exhaust, you would see something that looked like this. This is a schematic of an air pollution or a combustion particle that includes solid carbon spheres, very small, less than a micron in diameter, that would still agglomerate to make particles up to a micron in diameter. These are called ultrafine particles. And on the surface of these particles, there are absorbed hydrocarbons. So anything being burned or combusted, such in diesel exhaust or from a burn pit, the organics would stick onto these particles, and these would act like a vector to be deposited into the lung, since these are included in the smallest, in the 2.5 micron fraction. So the size determines where particles deposit. You can divide the respiratory system into the nasal and pharyngeal, laryngeal area, the tracheobronchial region, and the alveolar region. And this is a graph of particle diameter and deposition. Interestingly enough, both the larger particles and smaller particles deposit up in the upper airway in the nose, and particles less than 1 micron, clearly less than 2.5 microns in diameter, deposit in the tracheobronchial area and in the alveolar region. So what are some of the possible long-term consequences of burn pit exposure? And you've heard a lot about burn pits in the news. So the Institute of Medicine, which acts as a consultant to the VA, wrote this report in 2011, commenting on the Department of Defense sampling study that was done at the Joint Base Balad burn pit. This is the largest burn pit in Iraq. And the Department of Defense sampled at the burn pit edge and the base perimeter in 2007 to try to understand the contribution of the burn pit to local pollution. And there's no difference in the PM 2.5 levels measured at these two locations. And the conclusion of the IOM was that air monitoring data suggests that pollutants of greatest concern at Joint Base Balad is a mixture of chemicals from both the regional background and local sources other than the burn pit that contribute to high levels of pollution. So the burn pit is just one source of exposures that these troops had. Now, what are some of the concentrations in Southwest Asia? So I think to the credit of the Department of Defense, they conducted a sampling campaign in the middle of a war zone. So they set up these samplers at various camps, Bagram Air Base, Nols, Afghanistan, Balad, Iraq, Baghdad, Iraq, Talil, Tikrit, Taji, Al-Assad, other, and places in Kuwait. And they sampled irregularly, but had enough to come up with a very accurate annual averages of pollution. And in contrast, the US, where the standards are 12 micrograms per cubic meter. This is the military standard of 15 micrograms. The one-day average approved by EPA is 35 micrograms, but these are annual averages here, well above 12 to 15 in the range of 40 to 80 to near 100 micrograms per cubic meter. So very, very high ambient pollution levels in this part of the world. So if one were to look for effects on health, how would one study this in relation to pollution? And one is spirometry, and I show you here a spirogram with the FEV1 is measured at 1 second, and the FVC is where the participant, the subject, blows out completely, and emphysema. So what is emphysema? Emphysema, pathologically, you develop holes in the lung, and this is an example of a lung of a smoker with emphysema. But you can measure emphysema also using specialized software so you can measure smaller abnormalities than just you can see visually. And this is now being done for research purposes to come up with an estimate of percent emphysema for research purposes. So what do we know about exposure to air pollution and respiratory health effects? And this is just an example of some literature. There is associations with decreased pulmonary function and increased emphysema detected by CT scan. And this is just one study. This is the UK Biobank study, a large population-based study involving over 300,000 people who received spirometry and pollution at their homes with PM2.5 is linked to their residential address. If every increase of 5 micrograms of PM2.5 per cubic meter to the decrease of 80 milliliters of FEV1 and a decreased FVC, a decreased ratio, and there was an increased odds of COPD in the population. In a study that was published in JAMA, looking at longitudinal CT scans over 10 years in a US-based study, ambulant PM2.5, NOx, and black carbon, which is the soot I showed you in that schematic, at baseline predicted an increase in percent emphysema. Interestingly enough, there were similar findings based on occupational exposure in the general population, showing the same associations with job-related exposure to vapors, gas, dust, and fumes. So a common theme regarding health effects. Now, what do we know about asthma and air pollution, given the two cases I just presented at the beginning? Now, there's strong evidence in children for association with new onset asthma with traffic pollutants. And there was a study done in California that's very famous called the Southern California Children's Health Study that showed this association. There's weaker evidence in adults, but it's not no evidence. And there are good mechanistic studies showing associations between air pollution components with allergic sensitization, oxidative stress pathways, and airway remodeling. And a nice reference is an ATS workshop published in 2020 that discusses these associations. So now getting back to our deployed troops, what do we know about their health? Now, the Army Public Health Command actually published some very good studies looking at associations between encounters for healthcare and respiratory outcomes. And in one study, asthma and COPD encounters in pre-2006 deployers increased post-deployment with a 25% increase in these encounters post-deployment. Compared to US troops deployed 2005 to 2007 had more respiratory symptoms than asthma encounters over 4 years, 25% increase and 54% increase. And compared to US-based troops, person deployed pre-2006 to Kabul, which is a heavily polluted city, in fall 2011, had more respiratory and symptom asthma encounters, up 12% and 61%. So good observational evidence that there was some respiratory signal post-deployment. Another actually well-known study is called the Millennium Cohort Study. And this is the longest running cohort study in military history, supposed to go to 2068. And this was initiated, I guess, by chance just before our deployment. So you've got good pre-deployment questionnaire information. It included a representative sample of all services. And before deployment, persons are asked during the last 12 months, have you had persistent or recurrent problems with cough and shortness of breath? And then in 2004 and 2006, the same questions were asked in the past 3 months. In 2013, the question assessing health was, in the last 3 years, has your doctor or other health professional told you you have asthma? So what was found was that in terms of new onset cough or shortness of breath, in the land-based deployers, you had an increase of deployers versus non-deployment of respiratory symptoms that was not observed in the Navy or the Air Force. And in terms of asthma, 2013, persons not deployed with a reference group. If you were deployed and not in combat, you had no increased association with new asthma. But if you were in combat, both for men and women, you had an increased rate of reporting new onset asthma post-deployment. A relatively new disease, if you would say, associated with military service appears to be constrictive bronchiolitis. And this was first described by King et al. In a paper in the New England Journal of Medicine in 2011, and called Constrictive Bronchiolitis in Soldiers Returning from Iraq and Afghanistan. And 49 soldiers with unexplained dyspnea underwent lung biopsy, and 38 had bronchial wall thickening with muscle and fibrous tissue that was read as having constrictive bronchiolitis, similar to what I showed you on that slide of that last case. 34% of these patients had normal pulmonary function, 50 had reduced diffusion, and many had low normal exercise capacity. Only 6 soldiers had mild trapping, air trapping on CT scan, unlike what I showed you in that 4th case. So the question here is, this is a group of soldiers that underwent lung biopsy that had minimal to no physiologic abnormalities other than just a complaint of dyspnea. And many pulmonologists would not have biopsied these people, but would have said, let's just see how you do. And the authors of this paper were asked that question, and they said, well, these are young people in their 30s who couldn't do what they used to do. They couldn't run anymore. They couldn't pass the military fitness test. We had to do something. So they did lung biopsies based on, some of them had some abnormalities, other people didn't. 10 years later, they published a follow-up. Guter et al. Just got published last year, and they reviewed 50 cases of constrictive bronchiolitis, including 22 cases from the original series. And they commented on additional abnormalities, vascular with muscle hypertrophy, pleural inflammation or fibrosis, airway lymphocytic inflammation. And they're suggesting that the constrictive bronchiolitis seen post-deployment was not like the traditional constrictive bronchiolitis seen in other settings. Post-chronic lung transit rejection, autoimmune diseases, rheumatologic diseases can have constrictive bronchiolitis, mustard gas exposure, and the popcorn workers, food flavoring workers develop constrictive bronchiolitis, which is typically obstructive and rapidly progressive. The follow-up of these cases have not been as good as one might want, but what we know so far is that some of them have stabilized, some got a little worse, but it wasn't the rapid progressive constrictive bronchiolitis that was observed in these other more traditional cases. But so to summarize, there appears to be some small airway abnormalities, possibly other abnormalities associated with dyspnea primarily in a small subset of these deployed troops. Now, other clinical case series, and there are 2 centers in the country that have examined many people post-deployment. And this is the referral population, National Jewish in Denver. And of these 127 troops, 31% had asthma, 14% have what's called inducible laryngeal obstruction, so vocal cord dysfunction mimicking asthma, or that can occur due to some non-specific stimuli or during exercise, and rhinosinusitis. Now, in some of these troops underwent lung biopsy, and the comment on their paper is that 60% had bronchiolitis, meaning some small airway inflammation, but specific type of inflammation, the specific finding relative to constrictive bronchiolitis is not commented on. Granulomatous pneumonitis was noted with lymphocytic infiltration, pleuritis, similar to the comment by Guter before, and some vascular abnormalities. So perhaps some multi-lung compartment abnormalities. Another investigator at Brooke Army Medical Center would look at returning troops. And in 2 published series, the most common abnormality was asthma, as you can see from the slide. In the 310 case series, 23% had asthma, 11% had bronchial hyperresponsiveness, 6% had reflux, which can cause an asthma-like syndrome, and 5% had upper airway disorders. They did not do lung biopsies on their patients. So we're left with case series of asthma, biopsy showing small airway disease, where a deployment alone is treated as one uniform exposure. There's been no efforts to sort out what exposures might be contributing to what kinds of findings. So the VA funded through the cooperative programs network a study to assess this, and Paul and I are co-chairs. And the purpose of the study is to assess the association between deployment PM2.5 and health effects, lung health effects, and military and occupational exposures using a questionnaire. The outcomes are pulmonary function assessed by spirometry, respiratory symptoms, and asthma. So the design is that we're recruiting veterans from 6 VA sites: Boston, Atlanta, Houston, Minneapolis, San Diego, and Seattle, within 25 miles from the 6 VA medical centers. We updated DoD deployment records, so we recruited land-based deployers with updated residents and contact, and they come in for a 3-hour visit where they go through a very detailed deployment history, listing the bases they're at and the dates. We have a Google Earth map of 1,200 bases where the RA sits with the veteran and goes over exactly where they were based. They complete health questionnaires and do spirometry pre and post albuterol. Now, the target sample size is about 5,000, and we started in 2018, and we were doing, I guess I have too many digits on that, but we have about 2,000 people enrolled, and then COVID hit. So doing spirometry was not good to have people come in and do spirometry. So we're just starting up again. Hopefully soon we'll pick up where we left off. We have about a 33% response rate, which I think is rather good. So how do we reconstruct ambient PM2.5 since these countries don't have a sampling network like the US has? So there's a NASA satellites circle the Earth and can calculate something called aerosol optical depth. And particles in the atmosphere block sunlight by absorbing or scattering light. And AOD tells us how much sunlight is prevented from reaching the ground by these aerosol particles. So this is called satellite aerosol remote sensing. And the satellites measure reflected sunlight, and the satellite retrieval algorithms up at the satellite a lot of mathematical calculations on Earth extract particle reflectance from the total reflectance, which is from the particle and the surface of the Earth. They've got a signal to noise that has to be sorted out. And then you need to calibrate this AOD signal to ground level PM2.5 levels. So in the US, we actually have studies using satellite data to map the entire Earth that are linked to PM2.5 that's used to calibrate the AOD. However, in this part of the world, we don't have that network of samplers, but we have a lot of visibility data. So visibility can be a very good proxy for particulate pollution, and there are many, many military airports in this part of the world that have hourly visibility readings so that the airport can be used. And this is available through the Air Force, and this has all been saved. So over 2,000 military airports have these automated visibility readings, and you can see how visibility relates to pollution, and you probably can observe that around in what you've seen in the mountains here on the West Coast. So how do you do these calculations? There were 2 Earth-observing satellites called Terra and Aqua. that provides AOD data in 1 by 1 kilometer grids over 7 target countries that we're studying in that part of the world. You can match the ground visibility monitoring station with the corresponding AOD grid cell, and you convert the AOD to visibility starting in 2001. And then once you've done that, you can come up with a relationship based on previously collected sampling data and new data on the association of visibility and PM in the region. And then this information is summed over all the deployments to produce cumulative PM2.5 exposures over all deployments based on the base geocode. So the whole idea is to look at cumulative PM2.5. Does that predict lung function, asthma in this population? So here are some maps of just the AOD data retrieved from satellite. So this is 1 by 1 kilometer data of the summer of 2006, and the orange and the red here are high AODs, and these are low AODs, and you can see that this is Balad City, Baghdad, and these are highways. So over the highway, you see high AOD values, and over more remote region, they're green or yellow. The idea is, how do you get this to reflect PM2.5? And this is where we've used visibility to convert the AOD readings to PM2.5 readings. And this is average PM2.5 over 2 years with Baghdad and Balad. And joint base Balad is right over here. These are the PM2.5 readings. So the higher colors are above 80 micrograms per cubic meter. It goes down to 35 micrograms per cubic meter. And you can see over the roadways, you have high levels of PM2.5 in the urban areas, as you might predict. Now, what about more specific exposures? This is just a general air pollution. And we developed, with Paul's guidance, a 32-item exposure questionnaire. The next questions ask about heavy levels of exposure. Heavy means a sustained direct exposure in close proximity, meaning you could clearly sense it at the time. In other words, we didn't want to find out about some incidental exposure. We wanted to be able to report exposures that appeared to be heavy. Over how many deployments, how many months did this occur, the typical month, and how many days did it occur. So here are some of the questions we asked about burn pits. And these are good take-home questions you might ask in a clinical setting when you're working with a veteran. Heavy exposure to personally operating, working with trash incineration in a burn pit. Heavy sustained exposure when the wind changed. Heavy sustained exposure when it came into your worksite or housing, or working out next to the burn pit. Other exposures include combustion engine exhaust, fixed winged aircraft, helicopter engine, truck or Humvee repair, just for close proximity, generator fumes, and then ground particulate matter, natural dust storm, convoy operations, heavy dust other vehicles, such as a helicopter landing like my patient, road earth moving, or no fly days due to poor visibility. So I'm here in part to attend the American Thoracic Society conference that's going to be starting on Saturday here in San Francisco. And I'm presenting some of these findings in the first 2,000 participants in our study. So we had the participants answer a question: other than strenuous exercise, are you troubled by breathlessness? We defined chronic bronchitis as cough and phlegm in most days for 3 consecutive months of the year. Most had this in more than 2 years. And in the last 12 months, you had wheezing or whistling in your chest at any time. So in our questionnaire, we defined 5 exposures: burn pit, ground dust or engine exhaust that seem to track together, other combustion products, battery-related, other toxicants such as applying pesticides to one's uniform, and job-related exposures. And we looked at predictors of dyspnea, chronic bronchitis, and wheeze. About 7 or 8% of the population reported dyspnea and chronic bronchitis, and about 50% had wheeze in the past year. And we adjusted these analyses for smoking, BMI, sex, race, and age. And the other thing we did was we wanted to compare one category versus another. So we came up with a scoring mechanism and standardized the score to a maximum of 100. So you can compare the relative effects in this analysis of these various exposures. And we found that reported burn pit exposure was associated with increased odds of reporting dyspnea and chronic bronchitis. There was a borderline association between ground dust and engine exhaust with chronic bronchitis and wheeze, and job-related exposures. So just doing their job was associated with dyspnea and wheeze. So I think this is insight into some of the exposures, and it seemed to perhaps validate some of the information we've seen clinically and at some of the other studies that have been reported. So how does one then assess a patient? And here is just my suggestions based on the epidemiology in the clinical series. So you want to find out about deployment location and duration. How long were they deployed? What and where were they? What were their duties? What was their military occupation? What were their job duties while deployed? And ask specifically about, I think those burn pit questions I showed you are very useful. Dust storm, ground dust exposure, engine exhaust, other combustion sources, and what job they have that led to some exposures. Given what we're seeing, the association with allergy and asthma, it's important to find out about their previous history and their current symptoms. Clearly, they're smoking. I'll say that I didn't show you that, but smoking was associated with each one of these symptoms that I showed you in that analysis. And then what was your civilian occupational history or hobbies leading to exposures? So what tests might I do? Well, I would see clearly full pulmonary function testings with spirometry, pre and post bronchodilator. I think you've noticed from my two presentations for his patients that even though I did spirometry at one time, with asthma, you see variation in the FEV1. So you should really repeat the test to see if the FEV1 is changing more in a way that's consistent with having asthma. Inspiratory and expiratory CT imaging is useful in looking for findings suggestive of small airway disease, although it's not 100% useful given the findings of persons who got lung biopsies and still had constrictive bronchiolitis. Depending on your history, an upper airway exam, looking at vocal cord dysfunction, exercising tests, and allergy testing may be useful. Now, what is the role of a lung biopsy? And I think that really has to be individualized. I've seen people hurt by a lung biopsy. I saw one case where the patient had empyema post-biopsy, and somebody who initially had minimal abnormalities but did have complaints. So I think that has to be individualized, and we really don't know yet the natural history of deployment-related small airway disease. And I think a role for observation in somebody without major impairment or identifiable abnormalities is in order to try to define the history in that patient. As a pulmonologist, dyspnea is one of the most common problems that I see, even in non-deployed persons, and oftentimes you can't figure it out. You prescribe pulmonary rehab, weight loss, and observation, and sometimes people get better, and sometimes a diagnosis emerges. So I think you have to be careful not to, in my opinion, hurt somebody by doing an invasive procedure. Now, the other tools to try to diagnose small airway disease without biopsy are this computerized analysis of inspiratory and expiratory CT scans to quantify small airway disease. And that is something that can be done in research, for research. And there's been talk of introducing this clinically in the VA to investigate. We don't know yet what the cutoff is for sure of how much of this is going to be significant changes in diagnoses of small airway disease. And then something called oscillometry, where the problem with spirometry is you're measuring lung function during an expiratory maneuver. So it requires, you can't measure the airways when someone's at rest, breathing quietly. And this is a way where you can put in actually a sound signal into the airway and measure what gets reflected back. That can reflect airway resistance. So we actually have a VA Merit Review grant that was funded 3 years ago, just before COVID, to bring in persons from CSV 595 to do inspiratory and expiratory CT scans and oscillometry. And as we were about to start, COVID hit. So we're now trying to start that up again to try to investigate these subclinical abnormalities. So what information can you give for veterans? So last year, the VA added 3 presumptive conditions related to particulate matter exposure to get disability benefits. Asthma, rhinitis, and sinusitis are compensable now. All you have to do is say you're in this region. I'd say they know. And you had to have onset within 10 years of active duty. The veteran can register with the Airborne Hazard and Open Burn Pit Registry. And I have the URL. You can just Google this. It'll come up. And that's a registry that will help tracking these veterans. There's also a set of clinics in the VA in East Orange and Palo Alto and in Washington called the War-Related Illness and Injury Study Center, the RISC. And these are VA sites that will assess patients who have particular serious problems and try to make a diagnosis. So this can be referred to through the local VA. So that's my last slide. And I'd like to say thank you very much for being here and group online. I'm sorry I can't see you, but maybe one day we'll all be in person. And this is where I work, VA Boston. We have 3 large campuses, Jamaica Plain, Brockton, and West Roxbury. So let me end here.
We start with a couple, then we will open it up. It sounds like they've gotten rid of the burn pits. You made the point that after 2011 or 12, they've got, first of all, did they do that? And what did they replace them with?
Okay, they at least recognized we're no longer in Afghanistan and in Iraq. So they built incinerators. Mm-hmm. Yeah, now there's a country, there's an area, a US base in Africa called Djibouti, where there was a large burn pit for many, many years. And I'm not sure actually that's still operational. But I do have some. That's a very large burn pit. Even in the absence of deployment to the combat area, there was burn pit exposure.
And given at least that one study that maybe the burn pit was a marker of or a contributor to the pollution, but there are other contributors, including the dust and everything else. How much benefit do you think there will be if there's another deployment in a place, but there are not burn pits?
Well, that's a good point. So I think these are very dirty, dusty, highly polluted regions of the world, and there'll still be exposure to high level of particulate matter. And the combustion sources come from local combustion sources, from vehicles, from chemical plants. So I think the levels will be high. Whether some components will be not there based on what's burned at a garbage pit. Yeah, there may be, I think putting in incinerators with controlled incineration is much better than having smoke coming over the military base. But I would suspect there will be some benefit to that.
And what has been the practice and what is the benefit potentially of masking if you're working in or near a burn pit?
Well, that's a good question. I think that, whether you're having, a simple mask is probably not going to be good enough with a burn pit. Those particles, such heavy smoke, it's going to go around the mask, and it depends how long you can keep on a respirator or or an N95 mask, right? The problem is if you're doing strenuous activity with a burn pit, it gets pretty hot over there. The idea is to eliminate the exposure, not to try to control it just with a mask.
Got it. Yeah. Maybe one last one. Any lessons to those of us who now live in wildfire regions from what you found?
Well, I don't know if wildfires cause constrictive bronchiolitis. I think that perhaps the firefighters longitudinally as someone that can be followed. For that, I think any pollution. So let's talk about specific exposures. For example, over in Iraq and Kuwait, there were case series showing every time you have a sandstorm, you have more admissions to the hospital in children, for example, for asthma. So we observed the same thing when you have pollution outbreaks or when you get rid of, like the Atlanta Olympics, for example, when you got rid of the pollutants, the pediatric admissions for asthma went down in Atlanta. So I'm sure I actually don't know the wildfire epidemiology, but the idea is not to have wildfires, and these represent health hazards.
But is the hypothesis that the wildfires is the particulates that we're breathing in here during wildfire season, are they very different than the particulates that these folks will be breathing in? And
yeah, I would say yes, because that represents burning garbage, or this represents mainly the combustion of trees, right? I mean, so you asked a good question. So do we actually know what the component is of PM 2.5 that causes the health hazard? And I'll maintain we really don't. We really don't know which component it is. You asked me, are burn pits more toxic than wood smoke? I'm not entirely sure to answer that question directly, other by inference or guessing.
Okay, let us throw it open. I will bring a mic over and say who you are.
Thanks, Eric. Bob Harrison. Thanks for a great presentation. I've seen a couple of civilian who have also been deployed in Afghanistan and Iraq. So I just want to point out, it's just not a Department of Defense problem. I don't know how many hundreds of thousands were people who were contractors who worked there. And they have the same set of respiratory problems. So your study will be extremely valuable because I probably spent half my visit understanding the terminology, the other half looking at the map to try to figure out where they worked.
Right.
And then the other half of that, trying to figure out what their exposure was. So I guess I'm suggesting that it should be thought of as part of the occupational environmental health history of adults with respiratory problems. Just ask, have you worked or been deployed to Afghanistan and Iraq during this period? And not just the military, because many of us work outside of the VA setting.
Right. So the contractors are interesting. We actually have a contractor questionnaire for our military veterans because many of them went to work as contractors afterwards. We ask the same questions. So I think the issue of constrictive bronchiolitis is like the elephant in the room. Like, who actually has subclinical small airway disease? And how hard should we look for it is the question. Asthma, I think we should look for, no question, and even in your contractors. I think the issue of small airway disease, that subclinical causing symptoms, is still, I think, a question. Now there's a group called the Joint Pathology Center that looks at all the biopsy samples done in the DoD, and they reviewed all their cases over this long deployment time, and they only found 14 cases of constrictive bronchiolitis on biopsies being done in military personnel. 10 were deployed individuals, 4 were non-deployed. So there is some background incidence of this, what's called constrictive bronchiolitis. And what we don't know about is deployers, recognizing there are 2.7 million troops deployed. What is the actual problem? There is a problem. There's certainly no doubt there's a health hazard here. But I think, but it seems to be relatively small, but important. Let me just say small, but important.
Question from our medicine residents on Team G. You talked about the pulmonary effects of the pollution in Iraq and Afghanistan. What do we know about the cardiac effects or the neurological effects?
Right. That's a good question. So regarding the cardiac effects, you can first of all, it's more common in older patients who are more susceptible to that. So these are young, presumably healthy troops. So immediate exposure to PM can trigger plaque rupture, can trigger myocardial infarction, can trigger arrhythmias, which presumably these people didn't have. So we're talking about a more chronic cumulative effect. So in patients exposed to PM over many, many years, it can lead to progression of atherosclerosis in the heart and the carotid arteries, make hypertension worse, for example, and you're talking about long cumulative exposures. So the issue on these troops is the average deployment was something like a year or 13 months. So can that short of deployment cause long-term cardiac effects is a question. I think that's still an open question, but I'll say typically we see immediate and long-term. We don't really know about the intermediate, but presumably they've survived the short-term effects. Now regarding neurologic effects, one of the pathways of particles spread systemically is actually through the olfactory nerve, where In animals, you can actually put ultrafines in the olfactory bulb. They can migrate backwards to the brain. There is emerging studies of dementia, for example, Parkinson's disease, and PM2.5 exposure. These patients are young, but I think one goal of the registry would be to track health over time.
Just in terms of the pulmonary effects, the issue of short-term environmental or occupational exposure, I assume we know a fair amount of that from other exposures in the past. What happens if you've been exposed for a short period of time in your 20s to you over 30, 40, 50-year time horizons? Does it get better or does it get worse?
Well, that's a great question. So lung growth occurs in adults through the mid-20s. It ends a bit earlier in women. So what's been shown in younger children, exposure to traffic pollution will impede lung growth. So I think what we're saying is that we have a generation of young soldiers, 18 to the early 20s, who worked in a high pollution area. As you go forward, who are maybe healthy now, but over time, either your lungs are going to end up smaller. So whatever disease they were predisposed to get, say COPD, down the road due to whether smoking or other exposures, have we now shifted that curve to a more susceptible group? And I think that's really the question. But I've got to say, we really don't know about this intermediate exposure, its effect on health. We're hoping in 595 to have this cross-sectional survey and then follow them longitudinally to try to get at that.
We have time for one or two more. Paul, do you have anything?
Erica, since we have the time, I think it would be great if you could just contextualize a bit of the controversy about the way the term bronchiolitis obliterans, obstructive bronchiolitis, has been used, especially in the paper, the 2011 paper that got so much press, in that our own Kirk Jones has commented on the definition that they used was actually not the standard pathological definition.
Right. So there's some controversy of histologically, what do I call constrictive bronchiolitis? And the traditional histologic description includes fibrous tissue that narrow the airway, whereas in some of the case series, the abnormality is also muscular hypertrophy. And there's been disagreement among experts in the field as to what do I call this? And the last round, the follow-up of the King study, was that it had a small airway abnormality that appeared different than traditional obstructive constrictive bronchiolitis. But the first paper got a lot of attention because the concern was that it mimicked people with lupus, RA, post-lung transplant, or post other exposures with rapid progression. So perhaps that answers some of the questions. So when you read a description of constrictive bronchiolitis in the literature, the exact histologic definition may differ study to study.
Time for one more. I have to end then with this. This is almost nothing to do with your talk, but in a satellite looking down at San Francisco in the summer, you would think our pollution was terrible, and it's not. It's an incredibly foggy place. Can it figure out the difference between fog and pollution? It can, based on.
Right. Well, in a day that
you mentioned it was looking at visibility.
Well, there are different signals that get at coarse droplets versus fine particulate. So if you're looking at coarse particles that like water droplets that are condensed, it can sort out these signals. But I'll also say that when it's very cloudy, there is no signal. So there are days here where you're not going to get a signal.
Got it.
It also only images the Earth in the location twice per day. So you're getting a snapshot over time. So one day's exposure may not be captured accurately, but we hope is over time. If you look at cumulative exposure, it'll mirror what's going on in the region.
Got it. Great. Okay, we should quit. We'll see you back here next week. Art, thank you so much. It's terrific.
Glad to be here.